I'm specifically going to be talking about magnetic resonance imaging and actually trying to illustrate the potential for using this to assess vascularity. I've got to show that. I'm not sure that's really a conflict, but there we go. So what is the talk about? It's about, I'm going to present something about response assessment with imaging, and then talk about imaging, standard imaging in gastric cancer evaluation. And then the bulk of the talk really is about understanding some of the power of MRI and some of the methods by which you can get information about vascularity. And then finally, I'll touch a little bit on antivascular treatment and how MRI has potentially been used to monitor this, and some of the applications in actual clinical gastric cancer. So we begin with conventional imaging in cancer. It's all based on anatomical assessment. So with MR or CT, you can now get really quite detailed images. And here is an example of a patient who's had a head and neck squamous cell carcinoma, and you can see the detail in localization of that cancer within this patient's neck. Or you can get anatomical images that cover the whole body, and here's an example of a patient with lymphoma who has the entire body imaged with MRI within about a 25-minute period. And fantastic for looking at metastatic disease. So anatomical imaging is clearly important, but there is a problem here. And the problem is this, that when you start looking at treatment assessment, you are reliant on very basic features. So here's a pre-treatment patient with lymphoma who has nodular enlargement in the mediastinum, and post-treatment, the only way you know this has responded is because the size is reduced. So the question really is, what's the problem with that? And the problem is this. If you ask a radiologist to measure the size of this patient's mediastinal mass, he may do this, he may do this, or indeed, he may do this, or he may do this. So there is an element of inaccuracy in terms of how the size of a lesion is measured. There's also an element which is compounded by the new treatments that come along, in that actually post-treatment there may not be a size reduction, whereas there may have been a response. And this is something that Andy illustrated in his talk where he used CT to show a response. So at present, for all drug trials, we're really limited to using RECIST in terms of evaluation. And this is a CT or MR-based anatomical assessment tool which looks at change in size only and ascribes some thresholds for partial response and progressive disease. It's a very crude tool. So moving on from that, what are we actually doing in terms of imaging in gastric cancer? Well, for diagnosis, imaging is playing less and less of a role in cancer. There's been, although conventionally a double contrast barium enema where air is introduced into the stomach and barium coats the stomach, has a fantastic sensitivity for detecting gastric cancer. It's now being replaced predominantly by endoscopy in many, many centres, because not only can you make the diagnosis, but you can make a histological diagnosis by biopsy. The main role of imaging at the moment is in staging of disease, and the two techniques that are conventionally used are CT and, more recently, PET-CT for looking at local staging and metastatic staging. These are complemented with endoscopic ultrasound to look at depth of invasion. So where does MR fit into this? Well, let's start the talk about MR by saying that MR really doesn't look like it offers any particular benefit over conventional staging. But it has a role in assessing angiogenesis, and this is where it may have some power. There are a number of techniques that assess angiogenesis imaging-wise, and whilst we could talk about all of these, I'm going to try and present to you some of the options that are available using MRI. So the first thing I'd like to talk about is something called dynamic susceptibility contrast imaging. So what is this? Well, if you inject a gadolinium-based contrast and you effectively bolus track it whilst it passes through vessels, it will reduce your MR signal, where your MR signal is called your T2 star signal. It will reduce your MR signal as a result of passing through the vasculature. Now, the assumption here is that the contrast stays within the vessel, And if you look at the contrast passing through the vessel as a signal intensity time curve, you will see a reduction in the signal as the bolus passes through, and then a normalization of the signal once the bolus has passed. Now, assuming that all the contrast has remained within the vessel, then by knowing how much contrast you've injected and what your plasma volume is, you can start to get factors which relate to tumour pathology and tumour physiology, which relate to the relative cerebral blood flow or cerebral blood volume and mean transit time. Now, I say cerebral because actually it works predominantly in the brain because of the blood-brain barrier, but once you start moving outside of the brain, the applicability of this technique becomes less valid. This is what a typical signal intensity time curve looks like in a patient who's had contrast injected. This is where the bolus is passing through the area you're interested in, and by using an equation you can turn this into a contrast over time curve, and if you can do that for each one of your voxels in an image, you can produce a map. This is an example of the map in a patient where it shows mean transit time, relative cerebral blood flow, and relative cerebral blood volume in a patient's brain. So I want to move on from that and talk a little bit more about dynamic contrast enhanced imaging, because this is where predominantly the work with vasculature has been concentrated. What DCE does is effectively gives you your parameters which relate to tumour permeability. Again, it's based on injecting contrast, and this time it's based on looking at the signal increase that happens as a result of the contrast. You do generate a signal intensity time curve as before, and from that signal intensity time curve, you can input the time curve into a pharmacokinetic model and generate maps of particular features. For example, here, K-trans, which is related to the permeability, the extravascular, extracellular volume, and the plasma volume. So what does it actually look like, and how do you do it? So here is an example of a patient, again, with a head and neck cancer, who's had the same area imaged rapidly every 3 seconds during a contrast injection. And so what we're interested in here is what's happening to this patient's primary tumour and this neck node. And specifically, if you begin, what does the signal look like prior to contrast injection? What does the early arterial enhancement look like? And how does the washout occur? And you can see it washing out there. So a typical signal intensity time curve for T1 weighted imaging looks like this, where the contrast is injected, signal goes up, and then signal drops out. Now, why is this important, and how does this help us? In this patient with prostate cancer, you can see that there are 2 curves, one drawn from this region, one drawn from this region. In this patient, the curve from the right region goes up and then washes out. The one from the left sort of remains stable. And cancers typically have curves which have an early enhancement and a rapid washout, whereas benign areas tend to have more curves which stabilize like so. And it's these features in curves that can be used to help localize tumour. It can also be helped to try and predict whether a particular tumour is going to respond to a particular therapy. Radiologists like to look at images and like to colour images, and so people have started publishing papers which are very simple in the concept by looking at these curves in red, blue or green, depending on how the contrast enhancement varies over time. And in this patient, they've managed to show that localizing prostate cancer, you can do this by looking at the wash in and wash out based on these red curves. As I said before, you could take that information and you could put it into a pharmacokinetic model. And within the pharmacokinetic model, you can start looking at features which are telling you about permeability or the transfer of the contrast agent from your blood into the tissue and back, the extracellular, extravascular space that the contrast agent diffuses into, and also some information about the plasma volume. If you take the same initial imaging data and you run it through a pharmacokinetic model for the particular area that you're interested in, you can generate very nice color maps which look at the permeability within the tissue and the extravascular volume like so. A lot of studies are done on looking at how these features relate to patient prognosis, and particularly, and I'll talk a little bit about later, how these features relate to antivascular treatments. Having said all of that, you don't necessarily need to be very complicated in how you use assessment of vasculature using MRI. You can actually just visually assess a patient during dynamic enhancement. So here is an example where on pre-contrast images, it's almost impossible to see any lesions in the liver in this patient with lymphoma, but on post-contrast images, you can see very nicely black areas which are lymphomatous involvement. So assessing the vasculature is also very important because it gives you characterization of tissue and characterization of lesions. This is a patient with a potential liver metastasis, which you can see here on pre-contrast images quite nicely, and these images are then acquired every 5 seconds post-contrast, and you can see how that lesion responds to having the contrast agent injected in the vascularity. And in this case, you'll see that it has a very nodular pattern of peripheral enhancement, and just by doing this, you can characterize this lesion as being a hemangioma, not a metastatic deposit. Again, you can use the contrast assessment technique to try and improve your resolution in your imaging because you get more signal-to-noise ratio. So here's an example of a patient who has contrast-enhanced imaging of their chest to pick up nodules, which are about 5 millimeters or so in diameter, or to improve your coverage of your contrast enhancement assessment to provide whole body coverage, for example, in this patient with multiple myeloma within 7 minutes. So DCE is the predominant technique that is available in most centres, and certainly on a visual assessment tool can be applied by all radiologists. I'm going to talk a little bit about a couple of other techniques which are more experimental but have a slightly different power to the potential information you can get from them. First is arterial spin labelling. Here you don't have a tracer that you inject. You're reliant on blood being an endogenous tracer. You tag the blood magnetically, and then you take a series of images. You take one without the blood tagged and one with the blood tagged, and by subtracting the two sets of images, you're able to absolutely quantify cerebral blood flow. I say again cerebral blood flow because this is where most of the work has been done, and it's now being translated to other locations. So here's just the diagram which depicts what's happening. You tag blood at one end, you wait for that blood to enter the area of your tumour, and then that blood within the area of the tumour alters the overall signal there, and that's what you pick up by subtracting the pre and post tagged images. Just to show you again, if you're interested in a tumour which happens to be in this plane, you take a control image which has a lot of signal, and you also take a tagged image by tagging blood that's flowing up into the brain and imaging at a slice higher up, and you subtract the two, and the change in the signal there gives you information about blood flow. What does this look like? Well, this is an example of a patient with an extraaxial tumour, and these are the blood flow images taken from that patient, and this is the corresponding contrast examination. The importance of this is the signal that you're detecting is very small. It's about 1% total change, and this is why it's at the moment limited to looking at intracranial lesions where movement is not a problem and you can get multiple signal averages. The next technique I want to cover is diffusion-weighted imaging. Now, most people have heard about diffusion-weighted imaging in relation to cellularity, but not necessarily in relation to perfusion. So what is diffusion imaging? Well, if you look at Wikipedia and you search diffusion imaging, it will give you two definitions. It will say, definition one, it's something to do with the spread of particles along a concentration gradient. In definition two, it's something to do with the thermal energy of particles and the random motion of molecules as a result of that thermal energy. So which is it? Is it this, which is grains on water being bounced around by Brownian motion of water molecules, or is it this, which is the mixing of substances along the concentration gradient? Well, diffusion imaging is about Brownian water motion. It's to do with the thermal energy that water molecules have to move around. But more importantly, with imaging diffusion, what we're really interested in is what restricts the motion of the water molecules. And in most cases, that's to do with cellular barriers. So we can sensitize MRI signal to the microscopic motion of water molecules so that each pixel in an image reflects the diffusion of water within that pixel. What we can then do, for example here, in a patient with a lesion here anteriorly in the right side of the brain, is take several diffusion-weighted images at higher and higher diffusion weightings and take the signal from the individual pixel and plot it against the diffusion weighting. And you get this sort of exponential decrease in signal intensity. And from that, by fitting an exponential function to it, you can actually quantify the amount of diffusion of water within that one pixel. So just going on from that, what does the diffusion-weighted image actually show in terms of pathology? If you look at this and use this as a representation of a pixel, these are water molecules outside of the cell. These are water molecules inside of the cell, and there's a relatively lower water movement inside than outside of the cell. That's the normal state. There are pathological processes that can, of course, occur which alter that state. Here you can have more intracellular water and less extracellular water, and as a result, the overall signal within that pixel will change because there's restricted movement of water molecules within that pixel. Something like stroke, you might get early cell swelling, which will restrict extracellular water, as well as gives you more intracellular water, again causing the signal in your diffusion image to change. And in most cases with cancer, we're talking about an increase in cellularity within the pixel, which causes restriction of extracellular and more intracellular water to be present. So in most cases, diffusion-weighted imaging is used to look at cellular changes. But of course, water within blood vessels is also moving. And if you set up your diffusion-weighted imaging experiment to be done properly, you can actually generate information from that experiment about tissue perfusion. And what you effectively can do is take the signal intensity time curve I showed you, take the signal decay curve I showed you before, acquire many, many points along that curve, and then fit different functions to it. If you fit a bi-exponential function, you can generate a perfusion fraction, which tells you, hopefully, about the vascularity in the tumour that you're interested in. You can fit another type of function called a stretched exponential. That tells you about the heterogeneity of diffusion within each voxel. Or you can go to even more complex models, and in this case, a model called Verdict looked at vascular volume as an absolute quantifiable parameter, as well as intracellular volume and other parameters. What does the data look like? Well, here's a patient with a head and neck squamous cell cancer with a non-diffusion weighted image. You can see a cancer here anteriorly on the left side. And as the diffusion weighting goes up, you acquire several images of the same area. And by combining these images, you can produce maps which relate to tissue perfusion. In this case, by looking at the fast component of diffusion here, giving you perfusion value, or in this case, looking at the stretched exponential, looking at heterogeneity within each of those voxels. So I guess what I've shown you is that there are a number of new techniques which are available using MRI, which can give you additional information about tissue perfusion, and this can potentially allow us to monitor drug treatment. So why are we doing this? Well, because we know some of these techniques have a correlation with microvascular density. We also know that some of these techniques have a correlation with VEGF, and some studies have now started looking at these in anti-angiogenics and vascular disrupting agents. Out of all the techniques that I've shown you, really the only one which has been translated into preclinical models has been DCE MRI, and it's only just started to be looked at in clinical practice. Now, you can do DC MRI with small molecular weight contrast agents, which leak out of the vessels, or you can do it with larger contrast agents, which become blood pool agents. This is really just to show you that there is extensive data on DC MRI and various anti-vascular agents. And these are all the studies that relate to the anti-vascular agents, just referenced from a paper. This, again, is to show you that actually, if you look at particular parameters derived from DC MRI, in this case, the area under the signal intensity time curve, and you look at various tumor models, you can see a change in the parameter on giving the anti-vascular agent. That's about as far as we've got with this, and we haven't actually translated much of this into clinical practice. So, if we look at what we actually have got for assessment of gastric cancer in clinical practice, there is very little data out there on it. We're only just starting to use MRI, even conventionally, comparing it with CT to see if we can get the staging right. And in this paper published in 2010, we show that both MRI and CT have a very similar performance in staging of gastric cancer. We're only just starting, and you can see this is a paper from 2015, only just starting to understand the power of diffusion-weighted imaging. And in this case, looking at that apparent diffusion coefficient, they found that it has some ability to look at post-operative TNM staging. Well, what about DC MRI? Again, very recent paper only. They've looked at perfusion parameters. They've looked at these parameters called K-trans, VE, the area under the curve, and they found particular correlations in humans where the K-trans, for example, here, showed a correlation with the epidermal growth factor receptor expression. And so we're only just starting to find that DCE and vascular assessment in humans is feasible, and it may have a role, particularly in providing prognostic information. So to conclude, I just want to highlight that actually MRI offers more than the opportunity to just look at vascularity, and it's perhaps that is its greatest strength. So if we were talking about metastatic imaging, of course we could look at the vascular enhancement of the metastases across the body, and we would find that actually for a particular tumor type, not all METs are the same, and there is heterogeneity in enhancement pattern and enhancement intensity from one metastatic site to the next. This, of course, can then be complemented by looking at whole body imaging with conventional anatomical techniques, and with the new scanners that we have now available, whole body images without any Buscopan and obtained during free breathing can be acquired within about 7 minutes. You can also get more information about fat and water imaging, which effectively separate out fat and water images, again acquired within about 7 minutes. And one of the reasons you want to do this is because actually, if you're looking at tumor response, it's not only the vascularity that might change, but it's also the fat content in most cases, particularly with bone lesions, where you get an increase in your fat content after treatment. And finally, I talked a bit about diffusion imaging. And with diffusion images, of course, you image predominantly the cellularity, and you can use that cellularity information to complement your vascular information, your fat water imaging, to actually get a multiparametric assessment of the tumor and a multiparametric assessment of the potential response of the tumor to a particular therapy. So how does this all work together as a clinical example? Well, everyone has been using PET-CT for a number of indications in cancer, and this is just an example of a patient who had a PET-CT after colectomy, which shows a very normal pattern within the kidneys, but nothing else. This is the same patient who had a multiparametric MR performed, and on the anatomical image, you don't see anything in that region. On the diffusion image, you see a little bright area anteriorly, which indicates it's likely to be cellular. And the apparent diffusion coefficient map shows you restricted diffusion, which again shows you that it's cellular. And then the contrast images, pre-contrast, you don't see anything. Post-contrast, you see the enhancement occurring. And indeed, this is a patient who had a deposit which was not picked up by other techniques. All of this information can also be combined to give you quantitative information about that deposit, and studies are being done to look at quantitative information in terms of its prognostic value, and particularly in terms of its value for selecting patients which may respond to particular types of therapy. So it's not just about looking at the vascular information, but it's also about the cellular information and some of the other information provided by anatomical images. So why MRI? Well, as I've shown you, there are a range of mechanisms and models that are available that can provide you information about vascularity. Of course, there's no radiation involved. The cost is lower and lower as time goes on, and availability is getting more available pretty much throughout Europe. And then I think the biggest advantage here is that it affords you this multi-parametric approach of assessing vascularity, but in the context of cellularity and structure. But it's not being used at the moment, particularly in gastric cancer. Part of that is because it's a relatively new technique. There's a lack of awareness of what power it has. There's also some apparent complexity in terms of the quantitative imaging techniques. You do need to set up the parameters in a very precise way. However, if you wanted to do something qualitatively in terms of assessing the qualitative response to a particular therapy, there is less need for this complexity. There is some absence of standardization. I mean, one of the powers of MRI is it gives you the versatility to do a range of things, but that also leads to a lack of standardization, and this has been worked on. And in some cases, for the specific quantitative techniques that I've illustrated, there really isn't any reimbursement, so there's an impediment to taking that forward. So in summary, MRI can be used to assess vascularity. It is feasible. DCE MRI is the most commonly employed technique, particularly with anti-angiogenic therapy in preclinical practice, has shown feasibility in clinical practice. And my personal view is that vascularity should be used in conjunction with other information about the tumour as part of a multi-parametric evaluation. And work is already ongoing in terms of simplification and standardization of MR parameters so that they are generalizable to outside of academic centres. Thank you.
One of the questions that I have is using MR to assess vascularity, and this obviously makes sense when using anti-angiogenic drugs, the sort of drugs that we're talking about at this meeting. But going back to the issue about chemotherapy and why chemotherapy has to be used in many cases in combination with an anti-angiogenic agent, what is the impact of chemotherapy on tumor vascularity as assessed by MR? Have studies of this kind been, I mean, you know, the assumption is that chemotherapy is not going to have much in the way of an antivascular effect. I happen to believe that that's not true, that there could be some major effects, and this is one of the reasons why you want to use them with anti-angiogenic drugs. Do you have any insights into that?
So certainly, I think if you look at the standard imaging that's available, which looks at vascular enhancement, after chemotherapy, the vascular enhancement in the area of the tumour actually disappears, or there's a complicating factor that in most cases you get a tumour shrinkage as well, but you do also see a reduction in vascular enhancement. And Andy presented some CT images which showed exactly that that happens with chemotherapy and antivascular therapy.
So I mean, what is the implication? Is that suggesting that certain chemotherapy drugs or regimens could be causing a certain degree of vascular dysfunction, of vascular damage? Is there an antivascular effect, low-grade antivascular effect that can be actually, you know, induced, caused by chemotherapy?
I'm not sure the imaging data can support a causative mechanism. I think it can show that there is an effect, but whether that's a direct causative effect of the chemotherapy is more debatable. It may be that chemotherapy effects are upstream of that, and the downstream effect is the reduction in the enhancement.
Another question again, this is brought up by Andy, but this issue of, say, a anti-angiogenic agent, whether it's ramucirumab or bevacizumab or whatever, often having, little, if any, discernible, meaningful activity on their own. This is looking at it from the point of view, again, of, say, tumor response or survival, progression-free or overall survival. But if you actually look at vascular function, again, clinically, using MR-related methodologies, do you see, fairly good evidence that these drugs on their own are really having a meaningful antivascular effect? And if so, why doesn't it translate into a therapeutic effect?
Yeah, so I think the key thing there is meaningful.
Yeah.
Right? So you can pick up a change in the DCEMR parameters as a result of giving an antivascular agent. Whether that then remains as a sustained change or whether that results in any sort of clinical improvement is much more debatable. And whether that's because of the type of regimen that you've given, the duration of the regimen that you've given, or whether that's because the MR parameter is non-predictive, we don't know yet.
The challenge with DCMRI is that it shows a vascular response in virtually everybody. And whether it's sustained or not, maybe distinguishing people who are responding or not responding, but the initial drop in, or the initial sort of alteration in diffusion occurs in everybody who gets an anti-angiogenic. So it's not that helpful. And the other comment is, just to sort of, Bob, bring up what you had said, ramucirumab has monotherapy activity in gastric cancer, which doesn't clearly make sense to me why exactly that is. And I don't know, the effects may be something specific to, inhibition of VEGF signaling on the tumors themselves, which might be a thing unique to gastric cancer or other tumors where there's anti-angiogenic therapy. But it's, I think, a different mechanism than with chemotherapy, certainly.
Yeah. Good. Thank you.
Just add to that I think in terms of imaging, I think the opportunity there is not only to assess the vasculature, but to combine that with the other parameters that can be assessed. And it may be that it's a multi-parametric approach which gives you much more of a predictive power about which patients are going to respond and which patients aren't, but we don't have the data yet.
I've always been concerned about off-target activity of chemotherapy. You ever look at a completely irrelevant tissue? Well, a relevant tissue, let's take bone marrow, and look at MR changes there when you're attacking a hypernephroma. Because I can't believe that the chemotherapy is sure as hell not target-specific, unfortunately.
So something like the bone marrow, the well-described effects of chemotherapy as a result in the bone marrow, and in terms of the hyperplastic marrow, that tends to occur after the chemotherapy has been given. I haven't personally looked at other organs, but again, the data is there for us to go back and have a look. But I think that's an interesting concept. What happens to the normal what happens to the normal parameters in other organs as a result of chemotherapy?
I've seen everybody's slides, so I know what people are going to talk about. And he's got a slide on hypertension, 2 or 3 as a biomarker. Isn't there an imaging trick there to... it's easier to take a blood pressure, of course, but you're going to be imaging anyway. Is there a way you can image blood pressure?
There are some techniques that have been worked on the MR side to look at blood pressure, but it's probably easier to put a cuff around.
Okay.